Hey, welcome everyone. And this is the Geriatric Healthcare Lecture Series. My name is Barbara Cochran. I'm the director of the Deterny Center for Healthy Aging here in the School of Nursing. And today I'm representing the Northwest Geriatrics Workforce Enhancement Center, which sponsors this lecture series thanks to funding from HRSA, the Health Resources and Services Administration. I do want to remind all of you out there to please check in with your site coordinators if you have not filled out a profile form or if you don't have an evaluation form. Both are very important for us to be able to report to our funding agency so that we can continue to offer this lecture series. And I know all of you in Alaska are going to be relieved to know that Seattle survived its first snowstorm of the year, and it's now melting. And today I'm very, very happy to introduce Dr. Wayne McCormick, a long-term presenter in this lecture series, really offers a lot of important perspectives and has been a fave of attendees. He is a board-certified physician in internal medicine, geriatric medicine, hospice and palliative medicine, public health, and general preventive medicine. His research focus is health services research and epidemiology of dementing illness, Alzheimer's disease and other dementias, and other chronic diseases, including HIV infection in older adults. He is medical director of several local organizations, including hospice and long-term care facilities. He is also professor and director of the Division of Gerontology and Geriatric Medicine, which is the home of the Northwest Geriatrics Workforce Enhancement Center, and we're very happy to have you here today, Wayne.
Well, thanks, Barb. Thanks, everybody, for having me, putting up with me for the next hour or so. I'll be talking about HIV and aging from my perspective as a HIV provider for the past quarter century or so, and I've seen the epidemic go through multiple phases, and it's been a remarkable journey that now is entering an interesting phase in that the majority of people with HIV infection are over 50 years old now. And substantial numbers of people with HIV are coming through clinics with more advanced age in their 60s and 70s, but in addition, with a lot of illnesses associated that we would usually associate with aging that are occurring perhaps at younger ages than we would usually predict. So we'll talk a little bit about that, but this is going to be case-based. So I'll tell you about a bunch of cases, patients that I've seen, all of whom are still around, to ground our discussion in my talk in actual cases. So here we go. The first one's currently a 78-year-old man. In 2017, he's 78, and he's had HIV infection for at least 28 years, probably more. Recently, he's had weight loss occurring starting in 2015, but continuing over the past year and a half or so, and has had the insidious or slow onset of cognitive impairment over the past few years as well, mostly manifested by a word-finding deficit. He'll get in the middle of a sentence, just can't find the next word to carry on with his thought. Not an uncommon occurrence, right? We all have that one time or another. It's just that about every sentence he runs into this jam up. So word-finding deficit is his main cognitive feature right now, but he's clearly having trouble with short-term and long-term memory. On his laboratory data, he's a little bit anemic with a hematocrit of 30. He has a little bit of renal impairment with a creatinine of 2. His T cell count, or CD4 count, is 82. Viral load's 280,000, meaning he's not well treated for his HIV infection. The CT scan of his head looks okay, looks normal for his age. So he's admitted to a memory unit of an assisted living facility because he's having trouble taking care of himself, and he started on medicines for his HIV infection. In this case, 1 pill once a day, an integrase inhibitor with dual nucleoside reverse transcriptase inhibitors. So 1 pill once a day, easy to take. And what happens over kind of 2016, the second half of 2016, is he has slow, steady improvement in his weight and function. He's just a little bit quicker in his ability to get up, walk, and those kinds of things. And even his word finding has gotten a little bit better. Still has trouble with it, but it's a little bit better. But he's still having trouble with problem solving. He just can't quite figure out even slightly complex things. So still cognitively impaired. And now his T cells, after a year treatment, are 152. His viral load is undetectable, though. So what we shoot for in antiretroviral therapy for HIV is to suppress the virus in the blood to undetectable, still there, just below the level of detection of the lab test. And we usually shoot for a CD4 count to shoot up to several hundred. That would be what a younger person would experience on good antiretroviral medicine. But older people, not so much. Good viral load suppression, but not very good response of his immune system. That's because all of us as we age have something called immunosenescence, whether we're HIV positive or not. This happens to all older people, that just our T cells get a little worn out as we age. I'm not sure we were built to live, and at least our immune system wasn't built to live to as old an age as we are these days. But certain subsets of T cells become terminally differentiated. There's no fresh ones to respond to new infections. The naive or undifferentiated CD4 and CD8 cells, which are T cells, have reduced proliferation, and they don't activate very well. So there's more inflammatory markers around. This happens to everybody, again, not just people with HIV. So there's thymic kind of loss of fortitude and gradual insufficiency. If you go into a nursing home and immunize older people, all of whom are not HIV positive, with influenza vaccine, you can only expect about half of them to respond. So that's a marker that we all undergo immunosenescence. It's just much more accelerated in the setting of HIV infection. So no surprise that our 78-year-old didn't have a nice rise in his CD4 count that we'd like to see. The good news for older people is they do tend to take their medicine better than younger people with HIV. So viral load suppression, suppressing the virus to acceptable levels in the blood, actually is usually successful in older people. They have the best track record. So on this graph, you see that the top line is people over 60 years of age, and 80% of them, after 2 years, have viral load suppression to the undetectable level. So they're leading the pack with regards to viral load suppression. That's great. And it doesn't even matter which type of regimen they're on. There's lots of different choices now for antiretroviral or HIV medicines, and they have a good response regardless of the medicines they take with regards to viral load suppression. But here's the bad news. They bring up the rear guard in increase in CD4 count. So the viral load goes down, but their immune system doesn't come back up to snuff as well as younger people. Okay? So I want to make sure that makes sense. Feel free and ask me questions about it. And that also doesn't really depend much on which medicine's used. The older folks, by and large, can't muster an immune response, even though their viral load suppressed. Even though the HIV is well treated, they don't regain immune system function as well as younger people. Okay? So that's across the board. So let's talk about an even older HIV positive man. This fellow's 30 years old. Has a long history of pretty significant alcoholism. He's had heart disease. He had a MI when he was about 50, so 30 years ago, but has been stable ever since with regards to his heart. He has a little emphysema from long history of smoking, not severe, but mild. And he too has had this insidious but progressive cognitive impairment over the past few years. His partner, who was HIV positive, died 30 years ago, so he's been alone since, but he's a very social guy and has a wide network of friends, has done okay in that regard. But he's become a little bit more feeble over time and had a fall and broke his arm last year. As a matter of fact, his dominant arm, his right arm. So getting a little more frail. So he's on atenolol for his heart and lisinopril for his heart as well. Takes some baby aspirin every day, and he's also on integrase inhibitor and nucleoside reverse transcriptors inhibitors. Again, that's one pill once a day for his HIV, and has been religiously adherent to his medicines, like a lot of older people with HIV. On exam, he's a tall, pretty skinny guy, thin man, happy guy. His mini mental state exam is 22. For those of you who aren't familiar with that, it's a screening exam for cognitive impairment. A score below 24 is clear-cut cognitive impairment. Everybody listening to my talk would have a score of 30 here today. It's pretty easy to get a score of 30. The mini-mental includes recall, where you're asked to remember a few words immediately and then later. Your orientation questions, what's the date today, where are we, what floor are we on, that kind of thing. You're asked to draw a double pentangle, so drawing is involved. So lots of different realms of cognition are tested. Simple test takes about 6 minutes to do, but a score of 22 is clearly abnormal. On his MRI scan of his head, it shows some volume loss. Again, that's pretty common in an 82-year-old HIV infected or not, cognitive impairment or not. So that's not anything you could hang your hat on. His CD4 count is 380. It was as high as 750 a decade ago. He's been a long-term non-progressor, is what in the HIV community. It doesn't seem like HIV infection has really affected him that much. His viral load's undetectable on medicines. His labs look fine. So here's a question for you. Do you think HIV is the reason he has cognitive impairment? I told you a minute ago that he has this long history of alcoholism. He's 82. In our senior care clinic, where the average age is in the mid-80s, if folks live to the age of 85, their risk of having any dementia and Alzheimer's disease is getting up to 40 to 50%. So Alzheimer's disease would be a common reason why an 82-year-old would have cognitive impairment. Most cases of dementia in older people are actually multifactorial. When we take care of people in their 90s, usually there's 2 or 3 reasons they have cognitive impairment or dementia. Alzheimer's disease is just one cause of dementia. HIV is another one. So is chronic alcoholism. So is having multiple strokes. I told you he had history of heart disease, so he may have some vascular disease. Did not show up in his MRI. But in fact, he may have 2 or 3 causes of his dementing illness. It could be a mixture of Alzheimer's disease, alcoholism, and HIV. Although my guess is HIV is actually not the reason he's cognitively impaired, because he's been this slow progressor. It hasn't really affected his body much. And I doubt it's affected his central nervous system either. He has some other things that are making his cognitive impairment worse. I told you he was a thin guy, frail. He broke his arm in a fall. So he actually has frailty. Now, we all know what frailty means if we looked it up in the dictionary. That's actually a geriatric syndrome. So I'm going to talk a little bit more about frailty in a minute, but that's a bad thing to have. In and of itself, frailty as a geriatric syndrome carries a pretty negative prognostic indication. So with his alcoholism, he's got nutritional deficiency too. I think there's a bunch of different things that are causing his cognitive impairment. We should work on all of them to see if we can get things a little bit better, just like we do with anybody with dementing illness. How about his falls? Well, again, falls is a geriatric syndrome, just like dementia is a geriatric syndrome. And we have to think about it syndromically. Think about falls as having a bunch of different causes. There's seldom one cause for any geriatric phenomenon. Usually it's a whole bunch of different things figuring in. So in the case of falls, we'd have to think about his medical and neuropsychiatric conditions. He's an alcoholic. Maybe he's drunk part of the time when he falls. That's significant. Maybe the medicines he's taking are not mixing well with the alcohol. So a kind of a polypharmacy, medical and alcohol problem mixing in together. It's not just the medicines, it's not just the alcohol, it's them together. I didn't tell you about his vision or hearing, but if he has even mild hearing or visual impairment, that can play into falls as well. Maybe his strength has suffered, and his gait and ability to compensate for minor perturbations isn't as good as it once was. And maybe there's environmental hazards. Maybe he was a little bit inebriated and tripped on a rise in the curb or something. So we look into all those different reasons why he might have falls, try to work on all of them in hopes of making things a little bit better. Good. Here's the geriatric syndrome of frailty. It's actually 5 factors. 3 or more of these get you a diagnosis of frailty. So weakness measured by decreased grip strength. Well, how do you test that? What you do is you put 2 fingers, your pointing finger and your middle finger, in the person's palm and say, okay, squeeze my hand real hard. If you can easily pull your fingers out of their grip, they have decreased grip strength. If you have to pull really hard and can't do that, their grip strength's fine. Pretty simple. Slowness of gait. How we test that is with Mary Tonetti's Get Up and Go test. Let me tell you what that is. It's also very simple. We put people in a chair with arms, like the one I'm sitting in right now, have them stand up, walk forward 15 paces, turn around, come back and sit down. If that takes more than 10 seconds, they have decreased gait, but it's not just the timing of the Get Up and Go test. You actually want to watch how they walk. Do they have to push up using the arms, or can they just jump up out of the chair? When they turn to come back to the chair, do they show some unsteadiness? Is the movement of their arms normal as they walk? So you can learn a lot with the Get Up and Go test. Decreased activity is subjective. You just ask them, have you slowed down? Are you up and around as much as you used to be? Do you feel like you have low energy, or you just feel punk all the time, like you don't want to do much? And have you had unintended weight loss? So 3 or more, and your gestalt is geriatric frailty. And geriatric frailty, again, in and of itself, carries a negative prognosis. So what do we know about older people with HIV so far? First of all, when they take their HIV meds, they are able to suppress the viral load. The HIV RNA, its genome in the bloodstream, goes to undetectable. That's great. They do that better than young people. But their immune system does not recover like younger people's do. They don't have the immune fortitude to bounce back, even though the HIV meds are doing what they're supposed to do. And their mortality is higher because of associated other diseases that we're going to talk about some more from here on out. So let me tell you about another case here. Here's a 60-year-old man with HIV, a youngster compared to the first 2. He's had HIV for 24 years and has had non-Hodgkin's lymphoma, community-acquired pneumonia, that's what those acronyms stand for. He's had depression most of his life, but well treated off and on. atrial fibrillation in his heart. He's had obstructive sleep apnea that he wears a CPAP machine for. Many of you are familiar with that. He's had lipid abnormalities, hypothyroidism, high blood pressure, type 2 diabetes, and obesity, and he still smokes about a pack a week or more. He's on quite a few medicines. Diltiazem lisinopril for his cardiovascular protection. He's on warfarin for his atrial fibrillation, so Coumadin to thin his blood. He takes oxycodone for pain. He's got pretty bad arthritis because of his obesity. He takes citalopram for his depression, metformin for his diabetes, levothyroxine for his hypothyroidism, and a stool softener. And then for his HIV, he's on the same medicine the other two guys were, integrase inhibitor and dual NRTI, 1 pill a day. But he's got pretty significant polypharmacy there, right? Lots of different medicines to take. So he's 5'2" tall and weighs 220 pounds. So he's somewhat heavy. His lungs are clear on exam. He has the atrial fibrillation with a ventricular rate of 88. He has considerable obesity and lipodystrophy. He's been on HIV meds for a couple of decades, and it has changed the shape of his body fairly significantly. His CD4 count is 177. That's still too low. We shoot for at least over 200. So his is still low, even though he's had a good antiretroviral response. Viral load's undetectable. His blood sugar, fasting blood sugar, is 280. It's too high. His hemoglobin A1C is 9.2. You all who take care of diabetics know that we shoot for, closer to 6 would be a good hemoglobin A1C. His TSH, thyroid stimulating hormones, 4. That's good. But his cholesterol's high, 280. His LDL is getting high too, 190. So it's recommended that he add statins and insulin to his regimen. He actually does not like that idea. He doesn't like needles, refuses the insulin. He's willing to take a statin, but there's significant drug interactions with his antiretrovirals. And 2 months later, he's more depressed. He's actually gained quite a bit, not doing very well. And his lipids are just off the charts. So his cholesterol's sky high, triglycerides are sky high, and his diabetes is even worse off. So he actually gets involved with a psychiatrist and social worker and engages in walking. He walks an hour every day. He goes to Bastyr Institute here in Seattle and gets a naturopathic nutritional consult, and he actually responded pretty well. His weight over the next 5 months fell to 200. His diabetes actually went away. So his fasting blood sugar now is okay, and his hemoglobin A1C is also normal. He's still got a little bit of hyperlipidemia, and he's still smoking rarely, but it's a bit better. But his HIV is only one of the many things that are a risk for him. His diabetes and several of his other conditions actually together probably make his mortality worse. These days, HIV is not usually the cause of death in HIV-infected people. In fact, 90% of the time, it's something else. It's not just HIV. It might be alcohol or drug use. It might be a cancer that may or may not be clearly associated with HIV. It might be cardiovascular disease that may or may not be associated with long-term antiviral therapy. It might be liver failure from HIV and hepatitis C or some other terrible infection. So lots of different reasons that play into the cause of death for people who are HIV infected. And HIV may or may not be a predominant part of that. Cancer is a very large part of most HIV practices now. All kinds of cancers. Rarely are cancers not slightly more associated with HIV than not. So we're seeing much more cancers to deal with. The neurologic and cognitive impairment from the cases I presented, you already see that that's a prominent effect. Usually it's not bad enough to frankly be called dementia. Often it's just kind of mild and peculiar. So HIV-associated neurologic impairment is becoming more common. And the majority of the cases don't rate being caused dementia, but that doesn't mean it doesn't interfere with people's function. People with HIV infection have early menopause. They have testosterone deficiency. So osteoporosis is a huge problem as people with HIV age. And it's not entirely clear what we should do about that in HIV infected people. We know that we should give medicines to older women, for instance, without HIV for their osteoporosis. Not entirely clear what we should do for HIV infected men who are younger, but certainly we should at least make sure that they have vitamin D levels that are okay. That's easy, but we're not sure that fixes things. So the patient I just presented to you, to a geriatrician's eye, has something called multimorbidity. That's different than comorbidities. I told you, hey, he had sleep apnea, he had atrial fibrillation, he had diabetes. Yes, he's got HIV. So a lot of other things wrong. But the thing about multimorbidity is it's not linear. In other words, the co-occurrences of those diseases with functional consequences, the sum is worse than the parts and portends a poorer prognosis. In senior care clinic, in geriatric clinic, if I see somebody in their 80s with 4 or more conditions like that have functional impairment or cognitive impairment, their survival curve is roughly similar to people with metastatic colon cancer. You know, some people with metastatic colon cancer do okay for a while, but usually not. So when I see an 80-year-old with multimorbidity, the same kinds of things occur to me as taking care of somebody with metastatic colon cancer. I'm wondering, do they have their advanced directives in order? Do I know that their approach to care, their goals of care? If things get rough, do I know how to advocate for them? I'd be asking those same kinds of questions to my 60-year-old here who has multimorbidity. Here's a reflection of the nonlinearity of multimorbidity as it pertains to physical functioning. You see, that is not a straight line as you add diseases. Same thing with mortality, not a straight line. So it's actually an exponential increase in mortality as you add on more conditions in the situation of multimorbidity. So that's another significant geriatric syndrome, particularly applicable to older people with HIV, as some of them actually have multimorbidity. Now, I'm not here to tell you that all older people with HIV have this situation. I take care of 70-year-olds who have absolutely nothing wrong with them except HIV infection, and they're doing fine. That's great. That's the purpose of good antiretroviral medicine. It's just that sometimes they have all these other things wrong, and we can't just brush that under the carpet. We need to face that and help older people with HIV with their multimorbidity if that exists. There's certainly a lot of diabetes within HIV practices these days. Though the yellow bars here are people with HIV, the blue non-HIV in different age groups, and you can see that the prevalence of diabetes is really high in HIV populations. To some extent due to the meds, to some extent just due to proclivity or weight gain, but a very real phenomenon. So the 60-year-old I told you about, I mean, his risk for cardiovascular disease and HIV is most closely associated with age and with diabetes. The most important interventions for him are control of his diabetes, staying on antiretroviral therapy, and stopping smoking, which he has not done. Whether statins in lowering his cholesterol help a lot. Again, we actually don't know yet if in HIV populations, if statins treat hyperlipidemia and cardiovascular disease the same way they do in other populations. But we'll find out. There's a couple of good trials going on to actually learn that. Certainly most HIV providers are providing statins to a patient like I told you about, even if the cholesterol rise is caused by antiretroviral medicine. So a lot of things can happen to older people with HIV, and it seems to be true that it happens a little bit earlier than what we would think of as a normal aging process. They lose bone and muscle mass, they have alterations in weight, both directions, decrease in renal function or glomerular filtration rate, that's what GFR is, memory loss and problems that may or may not be significant enough to label as dementia. All of them have immunosenescence, that's very common. Frailty can come up, multimorbidity, and polypharmacy. So let's hit the polypharmacy thing a little bit. This last patient I presented to you was on a lot of medicines, complicated regimen. As people with HIV age, the number of medicines they're on for non-HIV reasons rises. So on the right on this chart, you see that a substantial number of older people with HIV are on a whole lot of medicines, some of them for their HIV and some of them for other stuff. It's increasing. So here's the regimen of the fellow I just presented to you. He's taken 1, 2, 3, 4, 5, 6, 7, 8, 9 pills in the morning and a few smattering the rest of the day. That's a lot of pills. And you wonder about adherence in that situation. So how do you all go about negotiating medication reconciliation in older patients on this many medicines? I'll tell you how we've come to do it in senior care clinic, because a lot of older people are on a whole lot of medicines. And think about yourself and whenever you've had to take a medicine more than a few times a day. Probably some of you have to do that now for one reason or another, but most of us aren't very good at that. The adherence rate in perfectly healthy people having to take a medicine 3 times a day, not good. Probably down around 50%. So the way we negotiate that in senior care clinic is, first of all, it has to be very individualized. Some people are totally adherent all the time. So we ask people these 3 questions. We say, you know what? Well, first of all, we have people bring their medicines in the bottles and line them up on the table every time, if they're willing. And usually they are. And we look at all his medicines lined up on the table and we say, you know what? Most people have a hard time taking this many medicines. Which of these are you not taking? You get a very different answer if you say, which of these medicines are you taking? It's much better to say, which of these are you not taking? People say amazing stuff. If you ask it that way, I've heard every imaginable thing. Every once in a while, somebody will say, you know what? I take every one of these every day without fail, just like you prescribed them. Actually, you don't hear that very often. Occasionally, you hear somebody say, you know what, doc? I'm not taking any of them. That you hear some, but not that often. But most people will finger 1 or 2 of them and say, I really just hate taking that one. It's too big, it catches in my throat, I just don't like it. Something about it. I think it's bad for me. So that leads into the second question. Of the ones you are taking, which ones would you like to stop? Or would you like suggestions from me about which ones we could stop? When you do this for everybody, it cuts down on the number of prescriptions about 20%. Some people, you stop a lot of things dramatically. When people say they're not taking any of their medicines, a natural thing is to lead into goals of care. It might be legit. You might advocate for them to just stop all of them, depending on the circumstance. Every once in a while, you end up increasing the number of meds by 1 or 2, but usually you cut down on 1 or 2 meds. It's kind of an interesting little tool because people are going to do what they're going to do. I mean, you can yell at them to take their meds. That doesn't actually get you very far. It's much better to negotiate it using some mechanism like this. So we talked a little bit about the neurologic issues associated with HIV and aging. Certainly the rate goes up in older people with HIV. And it remains significant even if they're taking their medicines religiously. Just about any other thing doesn't seem to have much to do with it. It's just much more common in older people with HIV. And even more worrisome is the fact that kind of mild cognitive issues are far more common, below the radar of a frank dementia diagnosis. Testosterone and estrogen deficiencies, very common, even in fairly young people with HIV infection. People in their 50s often have testosterone deficiency or estrogen deficiency. And this is our signal to get intensive about thinking about osteoporosis, because that's a very dangerous thing to have as we age, and we need to do something about it, at least with vitamin D supplementation, maybe calcium supplementation, and thinking about bisphosphonates or other manipulations to get on top of that. Because clearly, within HIV-infected people, the bone mineral density and fracture rates are much higher in people with HIV, and you can see how that escalates with age. Big problem. Problem we need to start addressing as our population ages with HIV. Here was an interesting study. This was not in HIV-positive people, but it's kind of a tickler. You know, there's a lot of debate these days about whether vitamin D is actually important to take or not. There's a big debate about whether any vitamins are worth taking or not. And in the press, you hear things go both ways. On the one hand, people, some organizations say it's just a waste of money. If people are having trouble taking medicines, certainly get rid of vitamins. Most Western diet contains enough vitamins for people to be okay. Others say, well, it probably doesn't do any harm, so if people feel like it's doing them some good, why not? What's the downside? There's maybe no downside to taking them. You don't overdose on vitamins. Well, this was a little study of vitamin D and postural sway in older people. The average age of these subjects was 70. These are not HIV-infected people. These are just older people. They were all vitamin D deficient at the beginning of the study. One group got randomized to not get vitamin D supplementation. The other did get vitamin D supplementation up to an appropriate level. And this sway test is, picture this. I'll describe it to you. Imagine you're standing on a piece of plywood about 3 feet square. And in the middle of the plywood is a little ball sticking up under the plywood. And you're supposed to balance on that. And there are sensors on your body to pick up how much your body sways as you're balancing on there. Okay? That's what the sway test is. And you can see that there was much more sway among people who were still vitamin D deficient compared to those who were vitamin D supplemented on the right. Kind of interesting, huh? And that means that vitamin D is doing something, presumably, that isn't just on the bones. And maybe it's on the muscles or on the receptors and proprioceptors. Something's changing that's probably positive. We just don't know enough about it. So I would say the jury's still out. I think we should have respect for what we don't know. And rather than tell people to just stop taking vitamins because there's no evidence, I'd say, you know what? Let's have respect for what we don't know. If it's not hurting people, maybe it's okay. to take vitamins. And I'm still bullish on making sure people's vitamin D is okay. We should do something about osteoporosis in older people generally and HIV-infected older people in particular. And I think this is probably a good idea. When I was practicing HIV medicine in the 1990s, before there was good antiretroviral therapy, everybody in clinic had a social work consult and had advanced care planning. Everybody got a durable power of attorney. Everybody got their code status straightened out, because at the time, HIV was a lethal condition. During the 2000s and even now, most HIV providers don't think that way anymore, because people are doing pretty well. You know, most people with HIV have successful therapy on the current antiretroviral regimens. But we're coming back around as people with HIV are aging and dying of things besides HIV. We probably should get a little bit more involved in advanced care planning again, especially for people with multimorbidity. Not my healthy 72-year-old who has nothing else wrong with them other than HIV. But maybe for the other ones, it's a good idea. Here's a study that was done in Denver where they had 238 subjects who were HIV positive. Not quite half of them had an advance directive, but it was the older ones, the ones who had maybe been around when HIV therapy was not so effective and saw some of their friends die. The younger ones didn't have advance directives. So I think it's probably a good idea to get back to taking care of this again, bringing up the topic of goals of care and advance directives in our older patients with HIV, because it's never too early to talk about that. And we need to find out what people want done in case they get sick before it's too late to ask them. So I have been a functional provider through the entire epidemic here. I witnessed the early days before therapy was available. I've had the pleasure of practicing during the antiretroviral area. And now we're in the chronic disease area dealing with comorbidities and aging. Fortunately, I'm a geriatrician and feel comfortable in that era. But what's interesting about the US is there's this wave of people coming through. The average age of people with HIV right now is about 52. So there's a whole lot of younger people and a whole lot of older people. And that wave is moving forward. The more HIV prevention is successful, even with pre-exposure prophylaxis. These days, people are getting therapy before they're HIV positive to protect them from getting infected. If we can tamp down the prevalence of HIV, maybe this will be the wave of an infection that in 20 or 30 years will be incredibly rare. That'd be an interesting success story. But in the meantime, we've got to deal with this chronic disease era, which will probably last the next couple of decades at least, as our HIV positive people age into their 60s and 70s and 80s. So that's what I'm trying to get everybody ready for with these geriatric pearls I'm sharing with you today. So I think we've come to the end, and I am happy to engage in a conversation with you all. I have not been tracking the questions Barb has.
Asked you to repeat what you said of older people not responding to vaccinations, and Billings VA is asking, or was that meds that you had said, older people, that was towards the beginning?
Yeah, no, that was vaccinations. I'll tell you about that study. It's actually been repeated a couple of times. If you go into a nursing home, now these are frail older people, not HIV infected, simply frail older people. Frail enough to be in a nursing home, not an assisted living facility, but in a skilled nursing facility. And give all of them simple influenza vaccine. and then 2 weeks later measure antibodies in their bloodstream to the vaccine you gave them, only half of them will have antibodies in their bloodstream, meaning half of them simply did not respond to the vaccine with an appropriate immunologic response. If you do that to younger people, it's true, not 100% will respond, which is why some people still get the flu even though they've been vaccinated. Or, of course, there's another host of reasons why that might happen. This particular year we're going through, it seems like a lot of people who did get antibodies to the vaccine still got a flu for some, either because the virus mutated a little bit or some other reason. But a solid majority of people in their 20s and 30s will respond with antibodies when getting an influenza vaccine. But only about half of older people will. That's immunosenescence. Let me make sure I answered your question, so feel free and ping us.
Okay, and then and if you could repeat my question, Dr. McCormick. In one of the presentations last spring, a lot of the symptoms associated with dementia sounded a lot like some of the stuff a friend of mine with Hep C is going through. I asked about this, and the presenter said that Hep C has a whole list of issues that belong to that diagnosis. Are there any symptoms that belong to the HIV diagnosis that resemble dementia?
Oh, sure. HIV, don't get me wrong, HIV is a cause of dementia. In fact, it's kind of interesting. In my practice, in the slide you see that's still up, the antiretroviral era, I worked at a nursing home, I still do, that cares largely for people with HIV infection. And it was incredibly gratifying to admit people with pretty significant dementia. I'm thinking of a couple of patients that were practically mute when they came in, completely dependent in activities of daily living from HIV dementia, who got all the way better on antiretroviral therapy. That's really neat when that happens. Now, it takes them half a year to do that, but it's very exciting to take care of somebody with dementia, because most of my patients with dementia who are not HIV infected don't get better, right? They get a little bit worse. They may have good days and bad days, but somebody with Alzheimer's disease, there's no medicine that's going to do that. So HIV does cause dementia. These days, it's often, especially in older people, it's not the only thing that's affecting cognition. There is this idea that people, even on antiretroviral therapy with HIV infection, still have mild neurologic compromise, because the central nervous system is kind of a reservoir, as is the lymphatic system. And so HIV in the central nervous system may or may not fully respond like the rest of the body to antiretroviral therapy, and there's still the risk of neurologic compromise with HIV. So it's still a cause of dementia, but these days often it's this mild cognitive impairment, kind of weird cognitive impairment. I'm taking care of a guy now who's actually very articulate, started out with a very high IQ, HIV infected for decades, a little bit older, and he seems pretty functional, but strange things will happen. He'll go get, fill up a plate with lunch from a buffet, take it over a table, sit down, eat a little bit of it, and then go get another plate full and sit down at another table, having forgotten he's already done it. Or he'll go out to cross the street and step out right in front of a car. So he's kind of does stuff like that, even though he seems okay in other ways. He's got clear cognitive problems, but they're not apparent in just casually meeting him. That kind of thing is becoming more common in older people with HIV. A little bit worrisome. You wouldn't say he has dementia, though, because he can do most of his activities of daily living. But he may go on to be more cognitively impaired as he ages. I'm not sure I got to the actual answer to the question there, Barb.
No, I think you did.
Okay.
Okay, let's see. How much of the health effects are due to disease process and how much due to the medications?
Well, that's a mix. Clearly, some
If you could repeat the question.
Oh, sure. How much of the disease process is due to the medicines and how much to the diseases in HIV with multiple complications? That's a story that's still being told. These days, because the medicines have changed, haven't they? I mean, there's been new discoveries, new regimens, new combinations. It may be that the most up-to-date combinations of medicines don't have the same implications as earlier ones. Earlier medicines had a fair amount of complications like lipodystrophy and diabetes, pre-diabetes. Then the newer ones maybe have less of that. But time will tell. They may have other effects that aren't good. If you're absolutely adherent to a medicine over decades, it may do some damage to you that takes a long time to manifest. So we'll see about the newer regimens, but I've certainly encountered patients who, it seems in retrospect, most of their problems are due to HIV and the therapy for HIV, although it might not be clear-cut. People with certain kinds of cancers that are associated with HIV but aren't necessarily the kinds of cancers that led to previous diagnosis of AIDS. But the rate of cancers is often higher, various types of cancers in people HIV infected compared to HIV negative people. So my general answer is that's a little bit hard to parse out. But in the long run, we still have to deal with these people. So there's no reason not to treat everything we can in concert and accepting of their goals of care, which vary widely, and do the best we can, individualizing care to each person.
Okay. Just want to get a handle on it. Okay. Is there any HIV risk transmission data comparing cognitively impaired elderly versus younger? Any guidelines or opinions for adherence monitoring for cognitively impaired HIV positive to prevent transmission?
Yeah, well, that's a good question. If people have cognitive impairment, they're going to have more trouble taking their medicines. That goes for anybody with cognitive impairment, HIV positive or not. And usually they'll need, depending on the level of cognitive impairment, some external system to help them with medicines. If they're in assisted living, can get help with medicines, that's great. If they have a loved one, caregiver, friend, associate that can routinize their medication adherence, that's great. They're going to need something like that. It's unusual to encounter people with cognitive impairment who can be religious about taking their medicines. Although, every once in a while you meet somebody like that. But they're going to need a system. More than just a Mediset. They usually need a human helper in some way, shape, or form.
To a certain degree, is HIV dementia reversible?
Well, yeah. I mean, I've had patients who got all the way better when their dementia was caused by HIV alone. It's usually younger people, and it was in the previous antiretroviral era. I got to say I haven't seen that this decade, but it wasn't that unusual 10, 15 years ago. Very gratifying when it happened. More common though, people would get some better. They'd get a little bit better, a little bit more functional, but clearly not all the way better. And then, it also happened that sometimes people didn't get any better. So in other words, they got excellent antiretroviral therapy and good viral load control, but their cognitive impairment did not change one iota. In fact, sometimes it even progressed. And there's this disparity between how well HIV medicines work up in the brain. Or maybe they had some other reason for their cognitive impairment that wasn't known at the time. So sometimes it works, and it's great when it does.
Do you have information about the HIV epidemic in undeveloped or underdeveloped countries, their access to medications and mortality rate?
I don't. I'm the wrong guy for that question. I don't know enough about it. I certainly know that actually the PEPFAR program has been instrumental in getting antiretroviral regimens to people in undeveloped countries and has had tremendous success. Whether that means that people are routinely having antiretroviral therapy available to them, I just don't know. I would doubt it, but that's not to say there hasn't been great success from the PEPFAR program, particularly in Africa.
Do you know very much about the microbiome or your microbiota? It is 70 to 80% of your immunity and affects your hormone regulation.
Again, wrong guy for that question. I'm fascinated by what's being discovered about the microbiome. I don't know much about it generally, and I don't know much about it particularly in the population of patients we're talking about. These people are on a lot of medicines that may well affect their microbiome. I just don't know enough about it to give you a coherent answer, as much as I'd like to.
Referring back to your nursing home example, do you see that there will be changes in educating older adults to get a flu vaccine? Might information be tailored to inform older adults about the effectiveness of the flu vaccine?
Yes, well, there's two initiatives, particularly in skilled facilities like that are important. One is there's a amplified vaccine that has a little bit higher success rate that's being used in people with advanced age now. So that's one good intervention, trying to boost the effect a little bit. The other thing is it's far more important for the staff of facilities to get vaccinated than for the patients to. The staff are the ones that are often the ones that spread around influenza. And so there's a huge push to get staff 100% vaccinated in hospitals and nursing homes, assisted living facilities. That's where the action is, not in trying to vaccinate 100% of the residents.
What about supplements? Would you suggest we limit those as well?
Well, I don't know. This is just like going over people's medicines, going over people's supplements. It's important to think about, well, is there a possibility any of the supplements are actually doing somebody harm? And harm can be cast broadly. If you think that an older person with or without HIV is undergoing economic distress by buying lots of supplements, it's okay to bring that up as a topic. Geez, you sure you want to spend all this money on these things that may or may not be doing you a lot of good? Or do you believe in them so much that you think it's really important to do that? Let's talk about that a bit. It's all in the conversation to really get to the deep understanding of what's driving them taking it. Is it something their children are insisting on, or is it something they want to do? And if it's not doing them any harm, maybe it's okay.
What is NRTI again, please?
That's a nucleoside reverse transcriptase inhibitor. Those were the first anti-HIV medicines developed. AZT was an NRTI, nucleoside reverse transcriptase inhibitor. And much of the early medicines for HIV were those. That medicine is not used hardly at all anymore, but there are newer versions of NRTIs that are used in concert with medicines called protease inhibitors, integrase inhibitors. It's become very sophisticated and very complicated, but the newest regimens are usually a combination of at least 3 HIV medicines put together in one pill, so it's easy for people to take.
It's an interesting question. Regarding immunosenescence, should geriatric HIV positive patients be screened for hepatitis B serology status and be revaccinated if negative?
Yeah. In our HIV clinic, hepatitis screening is, kind of 100%. It's for hepatitis A, B, and C. And if people are negative, they need to be immunized. If they're